Goldstein, and I'm the president and founder of Accountable Health, LLC. Accountable Health is a consulting firm, and we focus on population health management, including value-based care, contracting, program design and development, data and analytics, and digital health. Today, I'm honored to be guest hosting the New Normal webinar episode, The Emergence of the Payvider, Getting Closer to the Patient. We'll be discussing cutting-edge perspectives on the Payviders in the health and healthcare markets, the advantages and disadvantages of the Payvider model, and trends and market disruptions transforming the landscape of healthcare. Before I introduce our panelists, I want to take a minute to thank you for joining us today, as well as thank our panelists for sharing their time with us. As for the structure of this webinar, attendees will be on mute, and we have reserved time at the end for questions. So please place your questions within the Q&A box. I'll be monitoring that. You can review the recordings of today's webinar on www.newnormal.buzz. Now I'm going to provide some rather abbreviated introductions of our distinguished panelists, because all of the work they've done would create a rather 20 or 30 minutes worth of time here if I went through it all. So we'll start with Dr. Sunil Budhrani, who's a physician. He's the CEO of PayVider Solutions, developing innovative solutions to bridge the gap between healthcare payers and providers, including clinicians and health systems. He's an emergency medicine physician at George Washington School of Medicine and recently served as the Chief Executive Officer of Innovation Health, a payer-provider partnership between CVS Aetna and Innova Health. Dr. Budhrani founded one of the first telemedicine solutions, CareClick's Telemedicine, and prior to that, PrimeMed Urgent Care Systems. He also served as the Chief Medical Officer of the ACA health plan, Evergreen Healthcare, for the state of Maryland. Dr. Zeev, Neuwirth, physician as well, currently serves as the SVP for Clinical Care Innovation and Commercialization at Atrium Health, part of the newly formed Advocate Health. Dr. Neuwirth has held several roles within Atrium Health, including Chief Medical Officer and Chief Clinical Executive for the medical group, and Senior Medical Director for Population Health. Dr. Neuwirth practiced and taught internal medicine for 15 years and has an additional 15 years of experience in care redesign and innovation. In 2017, he launched a podcast, Creating a New Healthcare, now in its 6th year. And in 2019, he published his first book, Reframing Healthcare, a Roadmap for Creating Disruptive Change. And he is about to publish his second book, Beyond the Walls, which is available on Amazon for pre-order. Dr. Sanjay Doddamani, also a physician, is a clinical cardiologist and is the co-founder and former CEO of UpStream Healthcare. The company has grown to $1.8 billion in revenue with over 1,000 primary care physicians supporting 160,000 seniors in full risk arrangements. Prior to joining UpStream, he held several roles, including COO of Southwestern's Accountable Care Network. In 2019, he served in the federal government as a senior physician advisor at the Center for Medicare and Medicaid Innovations, or CMMI, as many of us refer to it. Prior to this, he was the chief medical officer of Geisinger at Home and concurrently led the Keystone ACO. So with those rather abbreviated introductions, I'm going to throw the first question to Dr. Budhrani, since Payvider is in the name of his organization. Could you tell us what exactly is a Payvider?
Yeah. Thank you for the opportunity of being a part of this forum, and with such distinguished company. We've traveled many paths with each other. I know worked with some of you in the past, so it's a pleasure to get back, even though it's still on Zoom. It's still we feel like those were the yesterdays these days now, don't we? But that being said, yes, as you mentioned, the word Payvider has interesting connotation, especially for depending on what your career looked like and how much you've touched healthcare, that means something different to all of us. But I look at the definition of a Payvider is a term that would express how the traditional payers, the insurers, the financiers of healthcare start engaging as becoming healthcare providers. The typical definition being a clinician, whether it's a physician, a mid-level provider, or even a health system. When you start seeing payers behave in the direct care delivery of services, then you start seeing how a payer operates as a provider, and hence the term Payvider. Now, the opposite can occur as well. You can almost have a prov payer, if you want to call it that way, but that isn't as smooth. Providers throughout the country are starting to, I would say, experiment and even do very well at become the financiers of healthcare. And so we're seeing more and more providers play in the game of payer or insurer or reimburser of services, in which case it's almost like the reversed kind of chronology of how services are delivered in healthcare. So I think of it in both ways because I've straddled kind of both industries in the span of my career.
Any other comments, Zeev or Sanjay?
Yeah, I mean, I think, you know, as Dr. Budhrani was saying, there are two types of Payviders. There's the provider group, you know, the classic Geisinger, Intermountain, that's a hospital system that moved into health insurance. And then, of course, the insurers who really increasingly have been acquiring providers. And so they're coming at it from two different places. But I think the sort of, you know, the point here is that it's really about managing the entire, you know, scoreboard of the entire field. So as a payer, you make money on the administrative side, some risk benefit as well. On the provider side, it's by providing the care. So by bringing both of these together, it's really a win-win. And so you're really making money across the entire spectrum. And also, I think that the advantage and the value proposition is around not just sharing the revenue together, but it's also in things like sharing the data. So, you know, one of the most challenging parts of having providers and payers separate is the data needs to come together in order to really increase the value proposition, to know how much you're spending, where the cost is, you know, where the efficiencies are, where you need to focus on. And when you can actually bring those two together, I really think that that is the ultimate value. That's a way to actually create ultimate value. So, you know, it actually, I think it is the future in terms of bringing these together.
Mm-hmm.
Fred, I'm going to say that both Zeev and Sunil are not only spot on. I'm going to go back to the history before we even knew what a Payvider was. We saw Kaiser, and, you know, I worked at Geisinger, and the opportunity to share across payer to provider, not only data insights, but what levers. And I think there was a recognition at the time that payers were very good at tracking the dollars, both incoming from CMS, also, you know, related to risk adjustment. And they were also really good at the payment side. The third leg to the stool was utilization management, and that caused a rub. And there's no question that they were still very good at it, but, you know, that's where there's a recognition that if they were to redo this, could they shift some of those, whether it was formal delegation or whether it was a much more, you know, sensitive and sort of improved experience way of working across providers. And so transferring that responsibility also allowed transferring some of the risk. And so it may have been born out of the Kaisers and Geisingers, but we now see the large base payers moving in this direction. And so that's, I think, what we're following. And now this has evolved to a point where we're now in this 2.0 era, where you're seeing the payers hold that, you're seeing the providers hold that, and you're seeing this new world, new ecosystem where both do.
And is this sort of as you talked about, the ability to integrate the claims data from the health plan with the EMR data from the provider, look at one overall data set as part of it, and then also the ability to say it's no longer per se the health plan pushing this care management approach or these on me. I, as a provider, have some input into that.
Hey, we'll take a stab at that if that's okay.
Sure.
I think the direct answer to your question has to also stem from an understanding that Payviders, in my mind, have about 3 different types of structures. Okay, you can have a vertically integrated organization where it's wholly owned and the payer and provider are a single vertical unit. Then you can have these horizontal integrations, which are basically mergers of 2 different independent organizations that may flip off a joint venture type of relationship. And then there's a third, which is, I call it a virtual integration, where 2 companies that are different kind of give the virtual appearance they're a single unit and are providing a unit. So it's important to understand that not all Payviders come in one kind of storyline, because that also dictates the success or the failures or the challenges that come with being a Payvider. Now, Yeah.
Could you quickly name one of those, each one of those groups, like an example?
Yeah, I think, you have a health system. Kaiser is a great example of a
Number one.
vertically integrated, single unit Payvider. Then you have the joint ventures, which I was part of one that started in a number of places across the country, which were joint ventures between Aetna and major health systems throughout the United States. Okay. And then there are the virtual ones, which I think are kind of interesting, because then you have these kind of de novo startup insurance companies that are maybe partnering with another organization, but they maintain their own independence, but they're being, perceived as a single unit payer or provider. And those are a little nebulous. It's hard to name those because that's just an in-between structure. It's easier to look at the two ends of the continuum. But to your point about data, I think the more integrated you are, the more you're able to exchange data and then do what I call the triad of benefit with data exchanged between a payer and provider. And, that's essentially, real-time care management, because you have claims and EMR data. It's predictive analytics, because now you have data to predict disease and be more proactive with disease. And then third is innovation. Like, if you can put all that data together, you can do some interesting stuff in digital health and telemedicine. So
Sunil, can I just, Fred, can I just jump in? So
Absolutely.
For me, the real sort of critical, tip of the spear, the real point here is that when payer and provider are separate, the real problem is a misalignment of business models and, and incentive. And I think, and I'm curious as to, again, Sanjay, you've had experience at Geisinger, right, with the health plan, and Sunil, you've had a lot of experience. To me, the magic is, and the real value proposition is when the providers have a business model which is consistent with value-based care, where it's not, it doesn't harm them. The challenge on a provider side, a pure provider side, is, we want to obviously optimize care, not do unnecessary care, cost-effective care. But if you incent the provider to do volume, it's, and I'll tell you this, providers, I don't know how we're doing it across the country. We're spending so much money investing in value-based care that we're only getting a fraction of that return back, and so that notion of really, what is the best model in your opinion in terms of how do you align it so actually the physicians and the provider groups are incented optimally to actually practice, and it's not just practicing, but it's also all the technology, all the infrastructure, everything, the entire business model, cascade, culture, protocols, processes, all aligned around that, where they're actually not disincented to do that, but they're actually incented. And I think what that would do would save tremendous amounts of money on the payer side, because we know how much money payers spend, as you were saying, Sanjay, about utilization management. I mean, it's a whole industry in and of itself. I mean, you wouldn't need utilization management if you incented the providers in the appropriate way. And I think that's where we need to get to. But I'm curious what you all think.
Yeah, I agree. I would just scratching my head because I talked about what the payers did well, but what they haven't done well is patient engagement, especially some of the historical, traditional payer models. And they recognize that the providers have an in with the patients. Patients, value their opinions of their primary care providers. And there's a very strong, net promoter score there. There's a strong relationship and a bond. And so to harness that and align that, financial model, usually an APM or some form of gain sharing, where at least the financial models align between the payer and the provider, creates a new opportunity for patient engagement.
Mm-hmm.
And so care management in the traditional sense done by a payer has had very poor adoption. Yeah. But care management, delivered through an integrated primary care solution, as we've seen with some of these models, both on the vertically integrated health systems, but also some of the new players in the, full bricks and mortar services, whether it's an Oak Street or, whether it's one of the other entities that have come on board. They've recognized the value of delivering an integrated care management solution.
Mm-hmm. You've mentioned, we've talked about EMRs, claims data. Are there other data sets that are important to begin to integrate if you want to be successful in this kind of a model?
pharmacy,
Mhm.
medication utilization for sure, really important. And then I think, the whole social determinants of health, which has an outsized impact as we're learning. And so, yeah, no, I think there's multiple streams. And then if we want to push it, it's actual, monitoring patients in real time. So, the point of need, and actually, I hope you don't mind mentioning, I talk about this in the first part of my book.
Sure.
And Sunil and Sanjay, you're intimately, when I say point of care, what comes to mind? The operating room, the ER, the hospital bed, the clinical exam. That's what we say. Point of care is where we are. But you know what? The point of need is not there. The point of need is where you're living your life.
The home.
It's the home, right? It's
Perhaps
the
it's the
workplace.
point of health.
It's the
versus
point
of care.
Perfectly
Exactly.
said. It's the point of health. And so I think that, the new emerging stream, in addition to all the other ones we've been talking about, is actually the stream of data coming from as we're living our lives. So, when I start getting depressed and I stop taking my medications and I start doing, exercising or walking and interacting, don't wait 3, 6, 9 months until I end up in the emergency room or, worse. Figure out that that's happening and catch me then. And so I do think that is a stream of data that we've already seen examples of it, Livongo, et cetera, where they're really following the, people at their point of need, at the point of health, as you put it. So it is definitely emerging.
Mm-hmm.
I agree totally. I mean, those data sets that Zeev had mentioned, I absolutely agree with. But then there's one last one that just came to mind as he was speaking, the patient subjective data. So the patient plays a big game in this story now. And I think in theory, a Payvider, when it's successful, can pull together all these pieces of information and do two kind of proactive, they're more than two, but they're two that come to mind that are what I consider successes. One is, like I said, predictive, proactive healthcare. Because you cannot do predictive, proactive healthcare unless people, entities, payers, providers are willing to share data in a repository that lets you be able to predict disease. And then you cannot do value-based care, in my opinion. You can't do outcome-based care and convince a doctor to take risk on disease if they don't have access to all the data transparently. So as much as we try to convince providers and health systems, take risk with me, and all of us know the industry well enough to know most payers are doing upside risk, not downside risk. So the way you hook a doctor on board is do upside risk, show them they will potentially profit from accountability, and then go to a negative. But most of the country is not in a downside risk situation with their providers. And you only get there when you have faith in the data that's being exchanged.
Sunil, I'm gonna throw out one more point, which is I don't think physicians, and we have 3 physicians here in the room, to say that you went to medical school to learn how to be a risk bearer, and the downside risk was going to somehow be attractive to physicians, and they were going to put their bet the farm. But what I do believe they recognize, and what they're increasingly frustrated about, is that fee-for-service has failed their patients, and where a lot of the non-clinical needs for patients, health equity needs, social determinants, just haven't been paid for or adequately resourced in a purely fee-for-service model. And that's what I think is why there's been such a demand for change into full risk or increasingly risk-bearing environments, where at least you could take those first dollar savings and attach them to providing services, whether it's medical transportation, food insecurity, addressing those health equity needs and deficiencies that providers feel are increasingly they're more rewarding experiences than with patients when they can truly solve for the patient issues.
Mm-hmm. So I'm going to throw this one to you, Sanjay, because as you talk about all this data, now I'm thinking, patient-reported outcomes, and start throwing that sucker across the transom. And they come in, and you've worked with some different systems. What sort of things do you set up so that Payvider group isn't just inundated, as you always hear, what am I going to do with all this stuff? Are there things to put in place that sort of screen that data or approaches to deal with that?
Yeah, I mean, there's been a traditional way of approaching, data, which is the conventional analytics. You've got, commercial platforms there that they do normalization and validation of your data. But ultimately, Sunil talked about this and Zeev talked about this, which is that you have to be able to re-stratify your patients and develop predictive models and go ahead of, get ahead of, when events truly happen and recognize the rising risk population and what their needs are. And then ultimately determine which patients you have true levers on. For example, in ambulatory care sensitive conditions, are there levers there to reduce hospitalizations or, not just drive a better clinical outcome and avoid the ER or the hospital, but be able to, earlier detect patients, increase screening programs. And I think payers are very eager to share where their gaps in care exist, the quality gaps, the HEDIS gaps, the STARS gaps, because they are also motivated to drive higher quality performance. But ultimately, that data needs to move. And we're truly now, I think, going to enter a very exciting era in healthcare around AI and prediction models and GPT, so that we can apply and harness that to earlier prediction, earlier recognition, and earlier intervention.
And I'm thinking also quickly, and you can get to it in a second, from a team-based approach, some of that data doesn't need to go to the physician. You've got somebody else to maybe handle that and deal with that and sort of head it off instead of having it always flow to the top, in essence.
I'll give you an example of what you just suggested. I worked in a joint venture PayVider model, and my primary responsibility was trying to figure out how to integrate giant healthcare delivery systems, a payer, Aetna, and a provider, whether it's Innova or the other, the other plans that were out there. And when we looked at it, again, the model's different because when you have two independent autonomous organizations and you're trying to create a vehicle for data to be exchanged, it's not the easiest thing in the world. I think it's a little bit easier if you have a payer that's brought in-house a provider mechanism and integrates data that way, or vice versa. So when you are trying to pull this repository together of data, and I always say, in healthcare, we always joke about, I need every piece of data. I need all the data in the world. And I used to laugh at that because I'm like, you give me 10 pieces. I made up a number even. You give me 10 pieces of the right data. I can assure you, you can predict a lot of things in healthcare. Just give me the 10, number one, and two, give me the right piece. So what we tried to do was try to get a platform that different parties were agreeable to sharing, not necessarily their own, whether it was an EMR or a payer built out platform, create a third-party platform solution that would ingest the right data so that you could get real-time disease information and then act on it in real-time care management. And to your point, we embedded a care management nurse team that sat at the top of this integrated data delivery system so that they could stratify the risk and then send patients to the appropriate venues of care, whether it was what Dr. Doddamani was mentioning, a primary care doctor, whether it was a telemedicine visit, whether it was an ER. So you could see this was almost like a virtual care management triage system that overlaid this data set of opportunity.
Fred, I want to just go back to what Sanjay said. I think, Sanjay, you're right. No one went into healthcare or medicine to, take risk. And that's not, but I do think that, data is critically important. It's huge. But I think the business model and the payment model, the incentives are probably the biggest hurdle and probably, I think, the biggest advantage that Payviders have in that they can control that much easier and manage that and actually transform that. So it isn't about risk, I think, to your point. I think it's more about liberating the providers and the ecosystem so that it doesn't have to do inefficient, ineffective work. So, right? So why do I have to bring the patient in when I know that I could do it through a text or a phone call? Well, you bring the patient in because that's the only way you're going to get paid, right? And so I think fundamentally data is a huge bucket of advantage, but I think one of the advantages I think that the Payviders have in what is clearly going to be a transition to value-based payment in our system. I mean, we're seeing MA, right? It's just now over 50% of all Medicare is MA, and that train ain't stopping, right? That's going to keep on barreling down the road. So we see signs of that. We see the direct to employer movement. So I think we know we're moving into that direction. It's just a matter of, where in the system and how quickly. But I do think the liberation is freeing up people to actually provide the most effective and efficient care. And quite honestly, think about how much time it'll save for providers and how much capacity it'll open up, where I can do a 5-second, 10-second text or some sort of messaging. Or Sunil, to your point, it doesn't have to be the doctor anymore. It could be anyone on the team, anywhere. We don't have to all come together in a clinic or somewhere. It could be virtual command centers. Now with automation could take all, over a significant. I mean, there are companies out there now that are in care management where an increasing percentage of the interactions are either asynchronous texting or automated chatbots, and they're finding that they're just as, if not more effective than the old way of doing it, where you literally were at the same time on the same phone call or on a video chat or in person. So I do think that that technology is sort of liberating us to be able to do that. It's enabling us, but it's the payment that is actually really kind of really critical.
I agree, Zeev. While I, submit to the fact that, physicians or providers didn't go to med school to learn how to take financial risk, they also didn't go to med school to perpetuate endless suffering and dissatisfaction as physicians. So, something has to give, and I think that's why you're seeing a greater adoption to value-based models.
Mhm.
If I may add just one thing that I think it's really interesting. 10 years ago, you wouldn't even heard of a term PayVider. It would not have existed. And I think the why is a really interesting question. Why do we talk about this right now? And I think it's a very interesting kind of tsunami in healthcare going on right now, because the big industry giants that ran healthcare, the payers and the major large health systems that ran it in their sphere, have been challenged by the non-traditional opposition, or what I call the Amazons, the Googles. So the large employers are fed up paying a lot of money for their employees' healthcare, and the deductible plans have had enough. So what encouraged these companies to get into healthcare? It's the cost. It was inevitable that this tsunami was going to happen. If you fast track that, it is also inevitable. What has happened is more and more organizations have realized if we don't change these legacy old school models, we are going to get taken over by large employers getting into healthcare, and we're going to have to form payer provider consolidations. And that's what we're seeing, massive consolidation in healthcare across the country.
Absolutely. I would add too, I think some of this was driven by the ACA with the 85% medical loss ratio, which limits the payers to profits off the top. And if you can get access to the bottom of that, that'll help as well. And interesting, Zeev, you sort of hit on this a little bit on the last one. We had a question come in and they said, you're talking about engaging people at home. Easy to say, hard to do. What are you doing differently that actually meets people, not just as patients, to get true relationships that generate engagement? I know you touched on chatbots and things like that. Are there others you can think about or that you folks are doing?
So, I mean, maybe Fred, help me out with the question. Is the question about what are you doing to bring care into the home? Like, what ways are you doing that, or into the community?
I think it's more about how do you generate true relationships with the patients, as actually not just as patients, but as people, is what they're getting at, not just engaging them at home, but developing that relationship.
After Zeev answers that from a standpoint of having done home-based care, I can add a little more as well.
Yeah, no, Sanjay, I'm right there with you. We've spent the last 3 or 4 years really developing a home-based care ecosystem. Hospital at home is one of the more well-known parts of it, but we also now have hundreds of virtual clinics in schools all over the state, now in YMCAs all over the state. And so, I think to the question, so we're doing it. It's not just talk. We're delivering care in the home now, from hospital-based care home, and actually I believe we're actually the largest provider of hospital at home care in the country, in terms of the number of hospitalizations at home we've accrued. But we're also hundreds of community virtual care centers as well, going now into primary care, urgent care virtually. I would say that the one, not the one, but one of the major advantages, in addition to everything else we're doing, and there's a lot to talk about, but one of the major advantages, and we've seen this, and I've seen it firsthand, is the moment that you take care out of the exam room and you bring it into the home, and this is, we have people going to the homes, plus, medical assistants who are in the homes with devices where, there's a doctor on the other side, and or just purely virtual. But the minute you're in the home, the minute you're seeing, you can see where the person lives, who they live with, what their house looks like, especially in the elderly, where are their medications kept? Are the medications disheveled? Do they have support? Is the home safe? Is it not safe? All the contextual stuff that yes, you can ask all the questions in the world. In fact, I'll tell you something, this became such a big point for us to, as we did dozens and dozens of customer discovery sessions, and now hundreds of customer discovery. They're now in the home, and we actually said that the home is almost like the dark side of the moon. There's no way to see it from your office. You actually have to go there.
Absolutely.
And so just being there in and of itself transforms healthcare delivery, because you can't but notice it. You can't. And so you're compelled to do something about it. Now, there are other things we've implemented, but I think that is the biggest change.
I'm going to add by also echoing and acknowledging the person who introduced me to all of you for this panel, Doug Goldstein, who said it's time for people to stop being treated as a patient and being treated as a person. And I think that's exactly right. It is, who is the caregiver? What kind of home environment is there? Is there social isolation? Is there problems with lighting, egress? Is there a shower rail? Is there, greater chance of fall risk? Can you do a true kitchen table reconciliation and you find 3 bottles of the same medication all expired? And so there are, I think, models of care. Most recently, it was at UpStream, and they had a home-based arm, and it was really to solve for those patients who are so dependent that they're unable to be plugged in. And so this is part of an omni-channel front door. It really creates the, some patients are fine with virtual, some can do the in-person, but there is a, population of patients, especially that top 5% of the patient population who are struggling between nursing home and oftentimes bypass the primary care physician's office. But developing a trustable environment really centered around consolidating the care plan that comes from within the primary care practice, I think, is the key to generating these longitudinal relationships. We see patients getting called from a call center, from a, from the pharmacy, from a whole host of mail order, from specialty. They get inundated with these calls, but none of them have the entirety of the picture. So they're just only getting bits and pieces of the elephant. And so nobody knows what the elephant actually looks like.
True. Yes, Sanjay, we have, what we've been correcting is we have some patients that literally have 4 or 5 different care managers.
Oh, yeah.
Right. I mean, you could have a, pulmonary care manager and a neurologic care manager and a cardiac care manager and a general care manager. And one of the things that we've begun to do, more than in the last 2-3 years, is actually create almost like a command center functionality around it, so that there is one Uber command center and everyone is communicating. And again, I think the digital, digital health revolution and the tech enablement is making that much more doable. But you're absolutely right. I mean, I have to tell you, I started doing home visits with some of the teams just to tag along. It is shocking. I mean, as many years as I practiced medicine in the office, going to the home a handful of times, you learn so much more about the patient, and you could do so much more, to your point, because you're there, right?
I'd point out one more thing to look at when you go in the home: their cupboards.
Yeah.
Oh, absolutely.
And what they're eating, as we did 20 years ago with the Medicaid population. You find out Meals at Wheels is delivering the inappropriate food to people who have diabetes and things like that. So fascinating area. You're about to add something. Go ahead.
Yeah, I think it's really interesting. When you go several thousand feet higher up in the air and look at this down, everything you're hearing described is, the evolution of healthcare in the United States, which going from the hospital to the home. And I think it was going in that direction because of the things we talked about with high deductible plans and employers taking the burden of care now in their own hands. But I think the pandemic, as devastating as it was, accelerated certain things that were inevitably going to happen, but I think they reduced the lifespan by 5 years. And what I mean by that is telehealth, telemedicine, remote patient monitoring, virtual kiosks, and then home-based care got accelerated by several years. CMS doubled down on codes to get it reimbursed. Technology opened up to make it more accessible. And I think it's really interesting that we are going to see, because people got a lot of their conditions addressed at home. And we were surprised in the payer world that even seniors adopted telemedicine anywhere from 200 to 800% more than they did before the telemedicine, because they were before the pandemic, because they were seeing their loved ones and staying connected with that way. So the home-based care is an interesting idea because they surveyed many CEOs of health systems. A major consulting firm surveyed CEOs of health systems and said, what do you think is going to happen to the care in the hospital over the next 10 years? And almost all of them unanimously realized that it was going to migrate from the health system. But the question was, what are they doing about it? And a lot of them are just looking at their 2-3 year plan, not their 10, 12.
Right. And go ahead.
Fred, I just wanted to go back to something Sanjay said, which, kind of speaks again to our theme here about Payviders. I think one of the big movements, and I do attribute it to the payer side, because they've been doing it, is because the payer side can look at the costs. They're really much more sensitive to that 5% that Sanjay was raising. And I think old school medicine was kind of, everyone was treated the same. So you would just come into my office, didn't matter if you had 5 diseases or 1 disease or 15 medications. I think what we as an entire industry have learned from the payers, and now I think have adopted in a big way, is that you can't treat everyone the same. Patients who are more complex, and whether it's because they're older, older seniors, frail, elderly, or they could be younger but with multiple complex chronic conditions, which is becoming increasingly more common. And we're talking about multiple complex, 4, 5, 6 chronic conditions on 15 to 20 medications. And we're seeing 50 and 60-year-olds. It's not just 70 and 80-year-olds, but that segment of the population needs, identified exactly. I think Sunil, you also spoke to it. We have to proactively identify those individuals, which in and of itself is a body of work, to identify them before they enter into the ED in the hospital, before they have that stroke or that heart attack. Because once they have that, the ball's rolling, the horse out of the barn. So we have to use the data and identify it, which the payers were, I think, ahead of everyone else. But now we're actually identifying. And then on the caregiver side, on the provider side, you have to construct an ecosystem of care to provide a different level of care for that population. And we all know that it's the Pareto rule, that 5% is going to be 40 to 50% of all the costs. You have to identify what of course is preventable. But I think that is one of the great advances in healthcare that has been happening and will continue to happen, is that sort of segmentation, customization, resource, where the resource is needed. And so I think that's an important part of this conversation if we're going to talk about the Payvider and value-based care ecosystem.
Yeah. So let me get to a question here. Sunil, you raised this issue of we doing these things because now we got a code for it, and they're keeping us with another code, and we're sort of addicted to this fee-for-service system. So this question came in: how do we overcome the massive incentives to stay in fee-for-service? The pain of transition is keeping many providers slow in that transition process, and this Payvider thing really is a transition. So how do we move that?
Yeah, I think it's inevitably moving now. Without a lot of the efforts. And I know I don't mean to sound, like this is an easy task, but I think the pressures on the healthcare system imposed by large employers are moving us towards an outcomes-based, value-based model. I think those pressures are real and they're serious. And like I said, the large employers are only getting larger in their space. And when they get larger, they command more influence in healthcare because it's about anywhere from 20 to 10 to 30% of their overall business costs are healthcare. So when you start having that dynamic, you start focusing on preventive and proactive care, not reactive care. So I think those changes are fiscally and financially happening as we go. Now, at the rate we will all like it, that's going to probably happen through consolidation. CVS buying Aetna. Who saw that? Honestly, who would have seen many of these consolidations and acquisitions happening? This is all payers and providers, believe it or not, that are trying to figure out how to integrate to compete against these outside firms. So it's happening, and some people don't realize it, but it is absolutely slow. In many markets, we still live in a fee-for-service world. But I think the heat is going to, with technology, AI, and all the things are happening, I think this is heat that we don't realize that's indirectly putting pressure on the system.
Brett, I know we're out of time, but Sunil talked about the big employers, and there's a question that came in on direct to employer.
Yeah. And they talked about thoughts of the employer and full service provider connecting or contracting directly. Okay, want to comment on that? And I'd also point out, Sanjay, at CMMI, they're pushing this as well in CMS, and they're going direct as well. So perhaps talk a little bit about that too.
Yeah, I mean, look, I really admire, the pace of progress, Sunil, you're absolutely right, has come from big providers, but it has also come from folks like CMMI. I mean, they've been so progressive to create the right, payment models that drive this forward now on the specialty side with OCM and with the kidney care choices. And you see the continued push. They're opening up data in a much more accelerated fashion. You know that with the FHIR APIs and the BDCA and the rules that have come in there. And so I think the opportunity is, it's a perfect storm occurring there in combination across, the flow of data, the flow of funds, and the recognition that, there needs to be change. But with regards to, I think, employer costs, Sunil is right. We're going to have an environment where we are no longer competitive as a nation. And so that's where I think direct to employer, while that's not my area of, specialty, I think is one that, is rightfully being asked is that phase 3, or does that happen right now?
And I think we're seeing a lot of activity behind the scenes right now. I mean, just look at Transcarent, right? So there's a company that is, Glenn Tollman, who's made some big waves in the healthcare industry. When he gets into direct employer, that something's going to happen in that market. So I think in the next 2 to 3 years, we're going to see some really, really big moves there. I just, Fred, one thing, I just saw a comment. Someone said, I want to be treated as a person, not a patient. I could not agree more with that. And I think we all agree with that. I think everything we're talking about is moving in that direction, but we have some legacy hurdles to overcome. But I really appreciate that point. Just wanted to say that.
Fantastic. Well, I know we've come up just about on the time, so we'll go ahead and close this out. I want to thank everyone today for attending, and thank you, Dr. Budhrani, Dr. Neuwirth, and Dr. Doddamani for your participation and great insights. I'd also like to mention there's a Healthcare Capital Markets and Innovation Summit, May 31st through June 1st in Columbus, Ohio. And if you use the Smart Health City, it's called, and if you use code Life360, you'll save $200. There'll be over 300 healthcare business folks as well as investors at the conference. And so with that, thank you both again. Thank you all again, I should say. And we'll post this recording on www.newnormal.buzz. I hope everyone has a fantastic day.
Okay, thank you.